sometimes if a patient has pathology or injury that prevents them from straightening their finger out, then if you shoot PA, then that's what you're going to get is closed joint space. And I think that's really what we've got going on with this patient. Is this doesn't look like a new injury. It looks like an old injury to me. But anyway, it looks like they've got some fusion going on. Otherwise, healthy bone. That's what makes me think that this is probably an injury, an old injury versus some sort of new incident. But if you have a patient who's got rheumatoid arthritis or some sort of injury where they can't straighten their fingers out, then it may be altogether more appropriate to take the images AP as opposed to PA. Had a patient that, and I might have told y'all about this guy in the first semester, but we had a patient that tried to clean out the ejection port of his lawnmower with the blade still running, and he got his hand too close to the blades, and it took off the very tip of each one of those fingers, but it also tore the ligaments and the tendons out from each one of the interphalangeal joints. So it broke the fingers and did significant soft tissue damage as well. Excuse me. He couldn't straighten his fingers out, so to get him flat for a PA projection. So we had to have him turn his hand over and shot him AP. So after surgery, his fingers would look an awful lot like that. So again, if the patient can't straighten their fingers out to get those interphalangeal joints perpendicular to the image receptor and parallel to the central ray, then AP may be warranted. Keep in mind, though, that whenever you're doing obliques, that the rotation is going to be exactly the opposite. If your oblique is usually external rotation from AP or from PA rather, then you may have to rotate in the opposite direction to make the images look right and proper. So technique, for whatever reason, sometimes our students will get locked in on technique compensation between PA and lateral projections, and they'll apply what they learn in the first section to pretty much everything that we cover. What I mean by that is the first thing that we cover is PA and lateral chest x-ray, and for a lateral chest x-ray, generally we need about a double the technique in mass than what we needed for the PA. So they carry that forward with them into every other exam type, and they think that for whatever reason we need to double our technique for every lateral that we shoot. And that's not true in most examples or in most anatomy types. For fingers, there really is no technique compensation between the two. Well, one is penetration with high contrast, so we want a lower KVP. What I mean by a lower KVP is I don't mean a 50 KVP. We don't necessarily need it that low anymore. Since our contrast is really controlled by the computer algorithm, we don't have to use as low a KVP as what we used to use with screens and films. So we can use a 55, 60 KVP even for fingers without really losing any kind of contrast. But we want to be able to visualize the distal metacarpals. We want to see all the applicable phalanges. We want to get visualization of the cortical bone and the trabecular bone. And just as a reminder of what those different bones are, portions of the bone, the cortex, the cortical bone, is the outer portion. That's that bright white stuff there, as opposed to the trabecular markings being that gray, fuzzy looking type stuff inside. So the cortex is the dense outer portion, as opposed to the cortical bone being on the inside, and that is that spiderweb looking goo on the inside. We also want to visualize soft tissue. If you remember back to the first semester, we talked about soft tissue indicators of fractures, fat pads, and we'll talk about those this semester as well, but we need to be able to visualize those. So we don't want our contrast too low, and we don't want our density or our overall exposure to be so high that we burn those out. So what we want, when I mention low MA, what I'm talking about is if you use 400 MA for fingers, let's say. First off, you might not get a time low enough to get a good exposure, and you might wind up with quantum model. So, in addition to that, your small filament size is probably not going to work on 400 MA, regardless of what your time is and your overall mass. Your filament current is going to be limited by the MA station that you select. So you've got to naturally select a lower MA station in order to get that exposure time. So the low MA works on a couple of different levels. One is, even though quantum model is an overall mass type thing, keep in mind from QA that the shorter the exposure time you get, the more variable and inaccuracy that you may see in your exposure timers. So even if you have an adequate mass value, if your MA station is too high and your exposure time is too low, then the mass that you may actually get is not going to be representative of what you actually set. So you may introduce quantum model anyway. So lower MA will allow you to use that small focal spot, and then appropriate time. Again, you're going to use small focal spot. Detail cassettes in a CR world is really the smallest image receptor size that you can possibly use. Remember, some of your imaging plate manufacturers use the same amount of relative pixels for different size image receptors, which means that if you have one image receptor is 10 by 12 and it's got 1,000 individual phosphors across the top, and we're just going to use one dimension, then if we use a larger image receptor, say 14 by 17, it's still going to have that 1,000 across the top. So in order to cover that entire imaging plate, those phosphors on the larger image receptor are going to have to be larger. So you lose some sharpness for recorded detail with the larger image receptor sizes. You want to keep your OID as low as possible. In our digital systems, of course, we've got our digital detector inside of the table, and most of your tables have removable grids. So you may have a tendency to want to remove the grid and still shoot with the detector inside of the bucky. And what you're going to do there is you're going to increase OID. So if that detector can come out of the bucky, if it's not hardwired into the system and you can actually shoot it on tabletop, you can reduce your OID by putting the image receptor on tabletop. Some of your hospitals might not want you to do that because those detectors are extremely expensive, on the order of about $100,000 per detector. So if they don't want you to pull it out, don't go to clinicals tomorrow and tell your supervisor that Nathan said that we have to pull these out and put them on tabletop. You're going to lose some sharpness of recorded detail because of the increase in OID. You're going to lose some sharpness of recorded detail if you don't. But if that's hospital protocol, then you got to follow hospital protocol. What you can do to overcome a little bit of that is increase your SID, if you can. So most of the time you're going to use 40-inch SID. If you can't get a low OID, you can increase your SID, and certainly no motion. Remember, motion is the primary thing that's going to destroy your sharpness of recorded detail. So image evaluation, what we're going to look at is a number of things. Rotation usually involves supination. So you have your patient to straighten their fingers out and they get the palm flat on the table. By the time you get around to the control panel, they start to relax their fingers, and what they do is they rotate towards the pinky finger. So they rotate externally towards supination. It usually involves the fingers being partially flexed, which is going to give us a couple of things. One is rotation, but the other is closed interphalangeal joints. So we're going to evaluate that by looking at the concavity of the bone, and we'll take a look at that in a second. And the soft tissue, the difference in soft tissue on both sides. And so I'm going to scroll up here and explain what this means. So the bone should be pretty hourglass shape. Each phalange should be pretty hourglass shape. So you got a small area here, you got a wider area on both ends. And each phalange is going to be a little bit different. Clearly the distal portion of the proximal phalanx is not as broad in appearance, and the difference is not as great as what you see on the distal and the middle. But it's still there. So you got this hourglass shape. If we turn to a lateral view, then what we see is, and this is not really representative of what the anatomy truly looks like, but the anterior surface has a great concavity. The posterior surface is either flat, or it might have even a very small and subtle convexity. All right, so if you look at the soft tissue should be symmetric. Now, a textbook may tell you to take a look at the nail bed. I recommend you just ignore the nail bed. It, in a lot of patients, it's not going to be centered over the distal portion of the phalanx. So you look again at the lateral and really look at your own anatomy, and if you push, you take the index finger of one hand and push on the palmar surface of the index finger of the other hand, then what you feel is soft tissue. If you push on the posterior surface, you don't feel so much soft tissue. So what you've got really is a difference in soft tissue between the anterior surface and the posterior surface. Anterior surface has about twice as much soft tissue as what the posterior surface has. So if you get rotation, what you're going to have, let's say this is the right middle finger, and it looks like middle finger, probably maybe ring finger, I don't know. But if we've got rotation would be towards supination, so it would be in this direction, so these fingers over here are elevated. What we're going to have is an increase in soft tissue, decrease in soft tissue, increase in concavity, decrease in concavity. And of course the nail bed's going to be off as well, but again, I've kind of told you to ignore that. Central ray alignment and collimation has a lot to do with the CR systems, especially recognizing those collimated fields. You want them to be as parallel to the plane of the image receptor as possible, and also to make sure that you've got 4 areas of collimation represented on the CR image receptor. If you don't have that, then what you may wind up with is a reader error. So poorly collimated field or a collimated field that's not aligned with the image receptor can mess up your image, even if you use the perfect technique. You want to avoid soft tissue overlap, so have the patient separate their fingers just a little bit. You want the IPJs open, so make sure that the hand is flat and your central ray should be parallel to those joints. So the joints should be perpendicular to the image receptor. Parallel, the joint space should be parallel to the central ray, perpendicular to the image receptor. And your comparison views sometimes are the adjacent digits, or they can be the same digit on the opposite hand. Keep in mind that the comparison views most of the time are just for patients with open growth plates. So most of the time you're not going to be doing comparison views on adults with closed joint spaces. not joint spaces, but epiphyseal joints, epiphyseal plates.